Hello everyone, my name is Victoria Rodriguez and I'm a PhD student at the University of California, Irvine, and my project this summer is entitled The Social Patterning of Uterine Cancer Treatment in the United States, Considerations for Health Equity and Long-Term Survival Outcomes. So to give you a little bit of background about uterine cancer in the US, it is the most prevalent gynecologic cancer, and the most common type of uterine cancer is endometrial cancer, which is cancer that's on the lining of the uterus. It's the highest among white and black women, and Latina women are often diagnosed at younger ages. And so even though it's already the most prevalent, we've already seen more of an increase over the last decade or so. There's been a 12.8% increase, and the largest increases are among black and Latina women, with the lowest increases among white women. It is the second most deadly gynecologic cancer, second to ovarian cancer, and black women are disproportionately affected by mortality for uterine cancer. And the 5-year survival rate, however, is relatively high at 81%, and it is the highest among all gynecologic cancers. So it's the highest among white and lowest among black and Latina women. And we've seen that there's worse survival among racial and ethnic minority groups that are of lower socioeconomic status, so those that either have poverty, lower education, or live in medically underserved communities. So already, just through incidence, mortality, and survivorship, we can already see kind of the social patterns of what's emerging from uterine cancer. And so NCCN stands for the National Comprehensive Cancer Network, and they have guidelines that have been widely adopted as a standard of care, and they are consensus-driven and evidence-based. So past research has shown that women are less likely to receive standard care and lower survival rates for ovarian, cervical, and endometrial cancer if they are of low socioeconomic status, black race, have no insurance, or publicly funded insurance. So again, we can start seeing the patterns that is emerging from the literature. And when we talk about specifically research that's on NCCN guidelines and survival, the majority of literature is focused on ovarian cancer, and we can learn from ovarian cancer that predictors for adherence include geographic proximity to and care at high-volume hospitals, whereas predictors for non-adherence include low socioeconomic status, increasing age, and atypical histology. So although this isn't for endometrial cancer or uterine cancer, we can kind of learn from ovarian cancer, but it really speaks to the need to do this research that looks at NCCN guidelines and uterine cancer in the future. So kind of to go along that, most of the research that focuses on gynecologic cancer is really focused on ovarian and cervical cancer. Usually it's because ovarian has the highest mortality rate, and cervical cancer is often thought of as the most preventable. So it really leaves a gap in literature just talking about uterine cancer. Research on racial and ethnic inequalities across the cancer care continuum, so from treatment to survivorship, primarily look at white versus black disparities and inequalities, and often leaves out Latino or Asian Pacific Islander and American Indian and Alaskan Native populations. But also, focusing only on race and ethnicity really limits our understanding of health inequalities. So we really need to apply an intersectional framework that looks at the multiple social statuses and positions one holds and how they interact with one another to produce health inequalities. So kind of to go along with that, my purpose of my research was to investigate the social patterning of NCCN treatment adherence for endometrial cancer among women in the United States. So I did a secondary data analysis that extracted data from the Surveillance Epidemiology and End Results Program, or the SEER program, between 2007 and 2015. So I specifically looked at the specialty databases Radiation and Chemotherapy Database and the Census Tract Level SCS and Rurality Database. And my key variables included demographic characteristics, including age at diagnosis that was treated both continuously and categorical, race and ethnicity, and neighborhood socioeconomic status. The prognostic factors included stage at diagnosis, histology, and grade. And my outcome variable was I created this variable for treatment adherence to NCCN guidelines. And I'd like to note a limitation here that I was only able to look at the primary or first course treatment because that was what was available through the database. So when I'm talking about treatment adherence, going forward, I'm only talking about treatment adherence to the first course treatment. And so this variable was informed and created by the variables of surgery, radiation, chemotherapy, lymph node dissection, and extent of disease. So my inclusion criteria, well, I started with 110,640 cases of uterine cancer. My inclusion criteria was that it had to be of endometrial cancer, it had to be a carcinoma histology, it had to be adult women 18 and over, and the tumor sequence number had to be greater than 1, meaning that it either had to be the first of 2 or more cancers the woman had in her lifetime, or the only cancer the woman had in her lifetime. My exclusion criteria included cases obtained from autopsy and death certificates, missing or no match census tract information, response category of not available for stage at diagnosis, and response category of unknown or not available for surgical staging or lymph node dissection. And so my final sample in my analysis was 84,013 individuals. Oh, it's not showing. So pretty much for my preliminary results, I'm only going to be talking about frequencies. So the total sample, approximately 40% of women received NCCN treatment adherence. And next, when I look at race and ethnicity, it's highest for Asian and Pacific Islander populations, followed by white individuals, whereas it was lowest among Black individuals, American Indian and Alaskan Native, and Latino populations. So we can really start seeing the trend of what groups get NCCN treatment adherence. When we look at by neighborhood socioeconomic status, it's highest among the highest neighborhood SCS income groups, and it's lowest among the lowest SCS neighborhood income groups. And followed by the middle SCS income groups, that is the next lowest. And last, when we look at by age, for the age groups 54 to 60, they had the highest NCCN treatment adherence, and the lowest groups was 69 and over and younger than 54. So, like I said, this was just preliminary analysis, so I still am in the process of analyzing data. So my next steps is going to be to do a multivariate logistic regression, and I'm primarily looking at, does treatment adherence for endometrial cancer differ based on social statuses, identities, and their intersections? And again, kind of going back to the intersectional framework, it's really important to me to look at these intersections of social statuses and social positions to be able to see what type of groups are most vulnerable to not receiving treatment adherence. So for example, just looking at only Latinas and then only low socioeconomic status doesn't really tell us the whole picture, but if we put it together and see what does treatment adherence look like for Latinas who are low socioeconomic status, that can provide us with better information of how to move forward and target these groups. And secondary, I also do want to do a survival analysis to see if overall survival differs for endometrial cancer based on treatment adherence, social statuses, identities, and their intersections. So the strengths of my overall research, SEER provides access to a really large sample size, and it's very representative and generalizable to the US population, which is really great. And really it allows me to account for multiple social locations and positions that are apparent in the United States. But I did have quite a few limitations within just the database that I selected. So like I said before, I'm missing adjuvant treatment, so I was only able to look at primary treatment, and the full treatment information is unknown. So for example, I don't have access to hormonal therapy, I don't have access to the dose of radiation or chemotherapy, and I also don't know if the patient had any comorbidities that could have influenced the treatment. I also don't know the physician specialty, whether it was a specialist or a primary care provider, and the location of the treatment is unknown, so I'm not able to see if it's low versus high volume hospitals or academic versus community centers. And the reasons for non-adherence are unavailable, which is a really big one and kind of lends to what we need going forward. We really do need more research, particularly qualitative research, that looks at the reasons for non-adherence to see if it's the patient's decision, if it's the provider's decisions, or what really are the factors that are making people not get treatment adherent care. And last, I don't have access to individual level SES characteristics, so that's why I had to use the neighborhood SES characteristics as the kind of, to fill in for that. So the learning experience, this was a really big learning experience for me. Thus far in my training, I haven't really done any type of project like this, and this was the first time actually analyzing my own data. So that was really a research process in itself, and really kind of thinking of how we get from the research question to the findings. So just from what database to use, making sure that they have the variables that you need to answer the questions that you want. But I think the biggest part was data cleaning, which really took up the most of the summer, which I had always heard of data cleaning, but I never really knew what that meant. And you know, everyone just says, oh, data cleaning, data cleaning. So now I really get what data cleaning means, and I appreciate how long it takes, and understand the importance of really taking your time and making sure that you do it right. Kind of going to more of like a more general limitation, I really saw the lack of taking a women's life course into perspective for the NCCN guidelines. So for example, age isn't really a factor that is included in these guidelines. Aside from fertility sparing options, it's not really thought of if a woman's 20 years old, what that means to have a full hysterectomy, removing the ovaries and fallopian tubes, and sending her body straight into menopause. Instead, it's just, well, do you think you want to have kids in the future? And if so, let's talk about that. So really seeing how these guidelines can limit women's lives and limit their decisions to get care. And last, really this learning experience made me think about what treatment adherence can tell us about survivorship. It's really taking it a step further from just whether or not someone survived and the mortality data associated with it, but really what treatment adherence can tell us about survivorship experiences and quality of life. So for example, whether certain groups may experience more adverse health outcomes if they're not getting treatment adherent care, or whether treatment adherent care even produces adverse health outcomes that really are not studied or discussed. So really the need to take it a step farther from just mortality data. And so my future career goals, I'm entering my second year in a PhD program in public health at UC Irvine. I'm planning my dissertation work to focus on some aspect of health equity within uterine cancer survivorship. So again, thinking of survivorship more of quality of life experiences and experiences that women have after cancer treatment, whether it's like 5 or 10 years afterwards, and really how we can help women after their experiences of cancer. And my long-term career goal is to establish myself as a health equity scholar with a tenure track position at an R1 university. So that's kind of my long-term end goal. And last, my ideas for future CEIF students is definitely to investigate these NCCN treatment adherence for various cancer sites. And this can be either using population-based cancer registries that look at both primary and adjuvant treatment therapies, or the use of hospital-based medical records or qualitative research to start to explore the reasons for non-adherence. And I'd like to acknowledge the CEIS program and Dr. Solomon, my primary mentor, Dr. Ilana Lebron, my secondary mentor, Dr. Robert Bristow, and Jenny Chang, who was instrumental to helping me understand data analysis and statistical software. Thank you.